Hi guys, welcome back. Next up is a critically important topic which for non-medicals is called as mini stroke, but for us is called as transient ischemic attack. And then TIA can evolve into a stroke as well. And in the later part of this video, I'll be describing various stroke interventions that we'll be doing to improve neurological outcome in our case. I begin by describing some mathematical data about 4 million neurons, 12 million brain cells, 15 million synapses. A lot of mathematical data, a lot of millions present here. I mean, that is the magnitude of death. These are the number of cells that would be dying every single minute. And that explains the fact that why need to be fast. And that's why the slogan came up, be fast. Be fast implies that we need to be fast with respect to diagnosis. And subsequently, we will learn that we need to be fast with respect to neuroimaging, diagnosing the type of stroke, and then doing specific stroke interventions to improve neurological outcomes. Well, for every 1 hour delay, let me say due to administrative reasons or the ambulance itself got stuck on the highway. This is a 60-year-old man, type 2 diabetes, hypertension, also a smoker, traditional atherosclerotic risk factors, and the ambulance is stuck on the highway due to a traffic jam or maybe some political protest going on and the ambulance is not able to navigate across. Then for every 1 hour delay in treatment, we find that the brain age of the patient is gonna increase by a whopping 3.6 years. So that means, let me say hypothetically, in this 60-year-old man, there is a 3 hour delay in treatment due to administrative or logistic reasons. Then you multiply 3 by 3.6. That means the brain of this person will deteriorate so fast that now the brain age of the 60-year-old person will be 70 plus years. That is why the slogan Be Fast is there, and Be Fast implies alphabet B would be with respect to balance issues. I mean, stroke is always going to be abrupt onset. So if any patient has sudden onset balance issues, or there is going to be an eye deviation, you will notice that specifically with respect to cortical stroke, there would be a eye deviation of a patient. Both eyes of the patient will start looking towards the side of stroke. That's a statement to be remembered. In cortical stroke, the person's both eyes would be looking towards the side of stroke. Like hypothetically, if this is left, this is right, then if the right middle cerebral artery of the patient is occluded, then both eyes of the patient would be looking towards the right. Then alphabet F, as is suggested from the diagrammatic representation as well, would be a sudden onset facial droop. I mean, even in Bell's palsy, we get a facial droop, but that in Bell's palsy, we will not be having a. That would be in the form of development of a sudden onset arm weakness. Alphabet S would imply that there is a speech impairment, and alphabet T is self-explanatory. Traditionally, we say time is money. But in this case, we are saying it is time to call 911. Time is neurons here. Time is the essence for this management of this particular case. So the Be Fast mnemonic is also used by us as doctors to educate non-medical people with respect to what is called as a brain attack. I mean, stroke or cerebrovascular accident is what we understand. From a non-medical perspective, the technical term used is a brain attack, and this Be Fast mnemonic aptly describes and aptly fills up the gap with respect to knowing what is development of a stroke from both a non-medical as well as a medical perspective. We will now focus on definition of stroke from a medical college perspective. I mean, anybody who's having a sudden onset alteration in the level of consciousness, because if there's going to be raised ICP, there's going to be depression of the reticular activating system, and that is why there is a sudden depression of the level of consciousness. Or if any person is having an abrupt onset, sudden onset neurological deficit. What I mean by sudden onset deficit could be in the form of either monoparesis, like his right arm or his left arm. Most of us are right-handed people. So this particular person is having his left middle cerebral artery getting involved, and therefore his right arm is not moving. He is not able to, let me say, raise his right arm to receive a glass of water from somebody. So that would be monoparesis. And in some cases, we might be having that classical half body paralysis also occurring. So in the later part of the discussion, I'll be talking about small vessel stroke also, where we get a pure motor paralysis. Apart from the arm deficit, there can also be hemisensory loss as well. So in the later part of the discussion, we'll be talking about that very famous thalamic Dejerin-Roussy syndrome. But at the moment, the main message is there can be motor deficit, there could be sensory manifestations occurring in a person, even visual deficit could be occurring. Not only can we be having eye deviation, but apart from eye deviation, there can be complete loss of vision as well. So it could be a monocular or it could be binocular visual loss. The reasons why this could be happening is either due to the involvement of the ophthalmic artery, which happens to be a branch of the internal carotid, or it could be damage to the occipital lobe as well. Then a large number of patients could be having cranial palsies as well. Raised ICP will anyway contribute to double vision or looking laterally. The sixth nerve palsy would come, but other cranial nerves can also get involved. So they can be diplopia, they could be a unclear speech, that is dysarthria. But suppose if the blood supply of the Wernicke's area or Broca's area is gone, then there would be a development of aphasia. And let me say, if the superior division of the left middle cerebral artery is blocked, as I've described in the earlier video, then superior division, whenever it supplies the Broca's area, then there would be motor aphasia. And if the Wernicke's area blood supply will go, then there would be a receptive dysphasia occurring in a patient because understanding would be affected. But if the main trunk of the left middle cerebral artery is affected, then both Broca's and Wernicke's area blood supply is gone, and that would mean that the person will end up with development of global aphasia. So most of the time you will be noticing, especially with respect to cortical stroke, that there could be a possibility of development of global aphasia as well as development of arm weakness. Plus, I've already explained that they can be facial droop, there would be facial asymmetry. We do come across facial asymmetry in Bell's palsy as well, but in Bell's palsy, then the remaining manifestations that I'm describing would not be present. And in Bell's palsy, we'll be able to demonstrate Bell's phenomenon, where on forcible closure of the eye, there would be uprolling of the eyeball, whereas in this case, that Bell's phenomenon would not be noticed. Then if it is a posterior circulation stroke, then we would be having ataxia. And moreover, in Bell's palsy, there would also be a history of retrospective infection occurring in this guy, following which these manifestations would have occurred. Bell's palsy is a pure lower motor neuron manifestation. And then part number 6 would be ataxia and vertigo, which I was saying is because of the posterior circulation of the brain getting affected. From here, the diagrammatic representation is only trying to tell you that we'll be having two areas. One is known as the core of the infarct, and then this core tends to expand, and subsequently you might notice that there might be an increase in the neurological deficit in cases of stroke over a matter of couple of hours. That reason for that expanding neurological deficit is because of the penumbra, and we have a couple of techniques by which we can measure the core as well as the penumbra. Like one of the tests that I can mention is CTP, that is CT perfusion study. I mean, we can do a CT angiography that can tell us, okay, which large vessel is occluded. So LVO basically implies a large vessel occlusion that can be determined with CT angiography. But a CT perfusion study can let us know regarding the volume of the core and the penumbra as well. And that penumbra, when it is expanding, will explain the progression of neurological deficit in a patient. This would be a traditional medical college kind of a description for stroke, but the B-fast mnemonic, as I said, is useful for both non-medicos and medicos to understand what is going on with the patient. And now our focus would be that what is a transient ischemic attack? I mean, why are we calling it the word transient? So let's assume that there are traditional atherosclerotic risk factors present in a patient. Like for example, in this image, you can see the richest man in India, Dhirubhai Ambani, with Bill Clinton and both his children. In this image, you can see Anil Ambani and Mukesh Ambani looking so young, and Dhirubhai Ambani, unfortunately, the richest man in India, we lost him to stroke. So, this disease, the ICMR recently came up with the data, and this was validated by AIMS Delhi as well, that they said that almost every 1 in 4 people in Delhi is at risk for development of stroke, primarily because of undiagnosed hypertension. And by hypertension, I don't mean only hemorrhagic stroke can occur. Hypertension can cause ischemic stroke as well. So if the richest man in India who could have afforded the best medical care unfortunately expired due to this medical illness, so that means the disease has to be taken seriously by masses. And TIA, transient ischemic attack, is a mini stroke where there was a thrombus development in any blood vessel in the brain, due to which there would be an occlusion of distal circulation and there would be neurological manifestations occurring. But thanks to the activity of the anti-clotting system in our body, we have protein C, we have protein S, we have antithrombin 3. This is the inbuilt anti-clotting system in our body, which is then cause a spontaneous destruction of the clot, and because of which you can see that revascularization has been achieved spontaneously. And as a result of it, since the blood supply is restored, the neurological symptoms of the patient will tend to disappear. So what you understand by the word transient ischemic attack is improvement in the neurological symptoms. This improvement usually starts as early as 1 hour. Most of the time, like this person suffered from sudden onset arm weakness, or there was a speech impairment as well, or both together were present, then if it was a TIA, you will notice that neurological improvement will start occurring. The power in the arm will gradually come back, and the person will initially lisp, and initially speech may not be clear, but gradually speech improvement can be seen. So improvement is seen usually within the very first hour. Though if they ask you in the exam that what is the cutoff to be remembered for transient ischemic attack, then the cutoff is that there should be a complete resolution of symptoms within 24 hours. Remember both the data, that improvement usually starts within 1 hour, or usually at the onset of 1 hour, or little beyond 1 hour, or even sometimes earlier than that also. There's no hard and fast rule. The point is improvement, if it has to occur, will begin, and the cutoff that is taken artificially is 24 hours. If the symptoms do not improve beyond 24 hours, if there's a neurological deficit persisting in anybody beyond 24 hours, then we are not going to call it a transient ischemic attack. We're not going to call it mini stroke. We're going to call it a evolved stroke. Obviously, we are not going to wait for the guy to suffer from irreversible brain damage. We should intervene fast, and that is why we do a non-contrast CT scan. Non-contrast CT scan is the first investigation to be done for identifying that there is a presence of a stroke, and you see hemorrhagic stroke can be picked up immediately on a CT scan. But ischemic stroke findings will take 6 to 12 hours to appear. We are not going to wait for 6 to 12 hours for hypodensity to appear on a CT scan and then say, oh, I'm going to treat the patient, because thrombolysis cutoff is 4.5 hours. So if the CT scan turns out to be normal, we are still going to thrombolyze the patient. I repeat my statement once again. Why are you doing a CT scan if CT scan report can be normal in ischemic stroke? Well, I am doing a CT scan to primarily rule out a contraindication to thrombolysis, that is hemorrhagic stroke. Stroke is of two varieties. 90% of cases ischemic stroke, 10% of cases hemorrhagic stroke. Hemorrhagic stroke manifestations will appear immediately on a CT scan. And hemorrhagic stroke is a contraindication for thrombolysis, because God forbid if somebody by mistake does thrombolysis in a guy with brain hemorrhage, then the hemorrhage will increase even further. Because what is the biggest side effect of thrombolysis? Bleeding, and the brain hemorrhage will tend to deteriorate. So the reason why we do a CT scan is not for, be able to see a hypodensity. That's going to take some time. Rather, why we are doing a CT scan is to rule out absolute contraindication for doing a thrombolysis. And if neurological symptoms in a patient is persisting more than 1 hour, it implies that this is acute ischemic stroke and we need to go in for interventions. Now I'm going to give you a scenario number 2 where you can see that there is an abrupt clot developing in any one of the cerebral arteries. It could be a possibility that the clot could have started from the heart. A large number of strokes could be cardioembolic in nature. So there could be a possibility that the clot could have started from the left atrial appendage. It could have started from the left ventricle after MI, and then the clot landed up in the brain circulation. So a lots of time you will notice that heart is initially involved. A large number of cases might be having atrial fibrillation. That atrial fibrillation will contribute to clots in the left atrial appendage, and then they are going to embolize to the distal circulation to the brain and cause an occlusion of a brain circulation. And now you have seen, or what I'm trying to show is that unfortunately protein C, protein S, and antithrombin 3 in this particular case, they are very much present. I'm not writing the name here, does not mean that they're not present. Protein C, protein S, and antithrombin 3 are present, but they were not able to lyse the clot, maybe because the size of the clot was relatively bigger. And as a result of it, what is happening is that there would be a irreversible brain damage, which will create a core and will also result in development of a penumbra. So the second diagrammatic representation is trying to show that there is no improvement that is occurring, and in those circumstances the diagnosis of this patient would be kept as AIS, that is acute ischemic stroke. As I've explained, in acute ischemic stroke the traditional hypodensity will take at least 6 to 12 hours to appear, and that would mean that there would be a substantial amount of damage. I mean, I'm not going to wait for that hypodensity to appear and then be sure about, okay, I'm dealing with acute ischemic stroke. We have anyway identified stroke because clinical manifestations are occurring, and therefore for acute ischemic stroke we will prefer to do thrombolysis. Usually there are two drugs that can be used for thrombolysis. In the current edition of Harrison, he has mentioned regarding a bolus shot being used of tenecteplase, which can be given in the CT scanner itself. Tenecteplase has an advantage, it can be given as a bolus, whereas the second molecule that we're using, alteplase, it would be given first, some part of it, 10% of dose of alteplase will be given as a bolus and remaining 90% as the infusion. But this thrombolysis should be done within 4.5 hours of symptom onset. With respect to window period, I want you to be remembering this fact that window period basically implies not from entry into the premises of the hospital. It is not the punch in time on the admission slip. It is rather gonna be symptom onset within 4.5 hours. And the current edition of Harrison has said that this is ideal if he says thrombolysis can be done up to. I said two different things. I said ideally speaking, we should be doing thrombolysis within 4.5 hours. But if they change the word not as ideal, they say thrombolysis can be extended up to, like patient came half an hour late instead of 4.5 hours, that is the window period that we were creating. Ambulance was stuck up in a traffic jam and they came at 5 hours of symptom onset, and the family member is asking you, sir, I mean, what's the plan? So we'll say, okay, we will still thrombolyze. So the upper limit, as far as the latest edition of Harrison says, that thrombolysis can be done up to 6 hours of symptom onset. The current guidelines are to give 10 tablets in the CT scanner itself, and then after we have done thrombolysis in a patient, he says subsequently do a CT angiography. When are you doing a CT angiography? You could have done CT angiography before also, not a big deal. I mean, if I have resources, I'll do it. But he says that CT angiography should be done after giving thrombolysis to the patient to demonstrate relief of occlusion, it to reveal that okay, whatever large vessel occlusion was present is now gone. So to prove that your drug is working, you need to do a CT angiography subsequently. And unfortunately, if the thrombus is very big and it may not open up on doing thrombolysis, if I'm having a failure of thrombolysis, I still have an alternative strategy. I still have alternative therapy that would be in the form of a thrombectomy. So in case of failure of thrombolysis with medicines, I mean, if medicines are not working, I'll tell the family members, no problem. We'll take up the patient in the cath lab. We'll take a vascular access, go into that brain blood vessel that is blocked, and we're going to remove that clot in one piece. That is thrombectomy. So nowadays we can do thrombectomy in those cases where there is a failure of thrombolysis. In the light of this data, I'm going to describe a case scenario before you of a 60-year-old man with standard atherosclerotic risk factors. He's having smoking, hypertension, diabetes mellitus, and today 8 a.m. he's shaving in the morning. And he says, he's telling me later, or his wife is telling me that he was standing in front of the wash basin. The mirror is in front of him and he's shaving in the morning. And the shaving razor, the person thinks, or the wife thinks, that the shaving razor accidentally fell from the hand of this guy into the wash basin. And this guy is, he was okay. I mean, he was holding the shaving razor, he was turning his head towards one side, and now he is subsequently telling you, or his wife is telling you, that there was abrupt loss of power in the right arm. So this particular individual was probably having a thrombus developing in his left middle cerebral artery, which would be responsible for this abrupt onset right arm weakness. So this guy at this point of time tried to call out to his wife, but he's later on telling you that, sir, though in the shaving mirror I could see that my lips were quivering, but no voice was coming out. So there is a speech impairment, which is again sudden onset. I mean, a couple of minutes ago, maybe he was talking with his wife about the latest political developments in India, or he was talking with his wife with respect to the voting scenario, which political party are they gonna plan to vote for, and now there's a sudden onset speech impairment that has occurred in this guy. Obviously, the symptoms will improve because in transient ischemic attack, as I explained, the symptoms are going to improve. But this is the usual manifestations that we are going to say with respect to a MCA territory transient ischemic attack, where there can be development of facial asymmetry. He might say that when I was looking at my face in the shaving mirror, I mean, my face was looking unrecognizable because of the sagging of the muscles on one side. So there was a facial droop, there was a right arm weakness and speech impairment occurring in this guy, which would be then subsequently showing a improvement. And he's saying, doc, I got the shock of my life when all these manifestations occurred. I don't want this to happen to me on a permanent basis, and that is why I've come to you. So transient ischemic attack is like, a life-changing event for an individual, and when such dramatic neurological manifestations will occur. Let me just change the perspective. It could be the same patient, it could be a different patient where there is a thrombus developing in the ophthalmic artery. Ophthalmic artery is a branch of internal carotid artery. So this guy is, let me say, at the moment he is watching television. He's watching election coverage, and he says, I thought that suddenly there's a black curtain in front of my eye. I could not see anything. I just went blind in one eye just like that. It could be monocular blindness, it could be binocular blindness. And he says, I got the shock of my life. Everything became black. and gradually after a couple of minutes there is a improvement in the vision of this particular guy. This description that I gave you, where a person is having a transient onset loss of vision which will shake the person to the core, is what is called as amaurosis fugax. Amaurosis fugax means transient loss of vision. The event is happening in the ophthalmic artery, which is a branch of the internal carotid. It can be monoocular, it could be binocular as well. And this manifestation that I have described could have occurred in the same patient 1 month ago, or it could be a different patient as well. But as you saw, there was an improvement that was happening. Let's take a point number 3 for a different case, or we can say the same case also, that if unfortunately if anterior cerebral artery is going to be involved, then there's going to be weakness in the legs. I mean, if it's the right anterior cerebral artery, then there would be weakness in the left leg, and vice versa. If both are getting involved, there could be paraparesis developing in an individual as well. So the main message is, whenever there's going to be an extremity weakness, it would correspond to the distribution of blood supply in area 4 of the brain. As you're aware, the area which controls the leg is supplied by anterior cerebral artery. The area that controls the face, arm, and the trunk would be the middle cerebral artery, and that is why these different manifestations can be seen. If the stroke has occurred, or if a mini stroke has occurred for the posterior circulation of the brain, let me say vertebral artery, then there might be cranial palsy, because of which the grandson of this old man was saying that grandfather is talking in a very peculiar fashion, that is nasal twang to the voice. I mean, this man is telling you later that my grandson was laughing because when I was talking, my voice had a nasal twang. This was singer na Himesh Reshmiya, to वैसे nasal twang to the voice. Or like when this person is trying to drink water or juice, or maybe trying to drink tea, that is when there is nasal regurgitation of fluids. So these manifestations tell us that possibly there is a posterior circulation of the brain that is getting impacted. Over and above this, it is not a guarantee that always motor manifestations may be seen. Sometimes it might be only pins and needle sensations in one half of the body, so hemisensory manifestations as well. It could be pins and needles, unpleasant sensation, burning sensation, but hemisensory symptoms can be experienced by an individual as well. The learning point for us is that all or any one of these, it could be a symptom, it could be any one of this, it could be many of these. If the symptom or a set of symptoms tend to show a spontaneous improvement, most of the time the spontaneous improvement will start occurring within the very first hour, and complete resolution is usually seen by 24 hours, though that cutoff of 24 hours has been artificially created. But the main message is, if neurological symptoms develop and then start showing a spontaneous improvement, we call it a mini stroke or transient ischemic attack. On the other hand, if the symptoms are going to persist for a duration more than 24 hours, we will say evolved stroke. As I explained to you, we are not going to wait for the manifestations to fully evolve. If a person comes to the hospital early, as now the awareness post-COVID in population has increased, if we determine it is acute ischemic stroke based on a CT scan, the report is normal in CT scan in acute ischemic stroke, we are going to plan a thrombolysis. Post thrombolysis, we're going to do a CT angiography. That CT angiography will help us determine whether there is a improvement in the large vessel occlusion or not. In majority of cases, thrombolysis will work, but if it does not work, we will have to send the patient to a cath lab equipped hospital where a thrombectomy procedure will be done, so that we can remove the clot in one piece and improved neurological outcome in the patient can be seen. The next question that arises is that, do all patients with TIA develop stroke? Well, the answer is no. It's not a guarantee that if somebody had a TIA, he will develop a stroke. But yeah, there is a possibility he can develop a stroke. And we now have a score available by the name of ABCD2, which is used to predict the chances of development of stroke. I mean, there are a lot of medical apps available nowadays. In those apps, in the drop down menu, you need to search for the ABCD2 score, and then you can just fill in the data as I'll explain to you, and you can tell the relative of the patient or the patient that what are the chances that he will be developing stroke. ABCD2 score, I mean, that was itself a question, predicts the chances of development of stroke over the next 3 months. I mean, this score is so accurate that it will tell you the chances. Though stroke can occur at any point of time, it can be 3 years later as well, but over the next 3 months, if this particular individual ends up with a neurological deficit, then this could have been predicted with the help of a ABCD2 score. Before I tell you the parameters, I want to tell you that in a large number of TIA patients, if stroke has to happen, it usually happens, most of the time it usually happens by 48 hours. Now, because the data is increasing, so I want you to pay attention to the words that I say. First, I told you TIA usually shows an improvement. If it has to occur, the improvement starts occurring by 1 hour. What is the cutoff for transient ischemic attack? 24 hours. Conversion of TIA into stroke usually occurs in, there are three different aspects. I'll say them once again, guys. TIA का जो improvement start होता है 1 hour पे start हो जाता है. The cutoff is for 24 hours. बट अगर वो स्पेसिफिकली पूछ रहा है कि TIA का conversion into stroke usually occurs around what time, then it usually occurs around 48 hours. So that hours वाला जो data I spoke, 1 hour, 24 hour and 48 hours, well, as I chose to be bilingual in this case both of the time, so that I can imprint the importance of the information here. So TIA has highest chances. The question's language was transient ischemic attack has highest chances of development of stroke by, your answer would be about the next 48 hours, though it can occur at any point of time. Now, in the drop-down menu, what are you supposed to select? You're supposed to select the age of a patient. If it is more than 60 years of age, we will be giving 1 point. So this is it's a point system, just like we read about curve 65 score for pneumonia, or we read about CHAD S2, CHAD S2 VASC score for atrial fibrillation. In a same spirit, we are today studying regarding ABCD2 score for predicting the chances of development of stroke. So in the drop down menu, the second parameter that you will select will be the blood pressure value. If our patient is hypertensive or is taking medication for hypertension, that would still be 1 point. And measuring blood pressure is anyway of paramount importance, because if a person is going into hypertensive crisis, anyway aggressive control of BP is required. Then alphabet C stands for clinical features. So these clinical features can be many, but they take into consideration the predominant ones. One of the predominant manifestations that occurs, because one of the commonest blood vessels that is involved is the middle cerebral artery, so we get arm weakness, though in some cases we might be having only speech impairment occurring. For arm weakness, we give 2 points, so that is a data which is optional if you want to remember. Usually they ask you, the data with respect to interpretation, they might ask you in any set. For NEET, they'll just ask you the name of the parameter, age, BP, clinical manifestations. Do remember, it is clinical features. It is not past history of stroke. In one of the previous sessions in the exam, both in NEET PG and FMG, they asked about ABCD2 score and alphabet C. They did not write clinical features of stroke. They said which of the following is not a feature of ABCD score, and instead of writing clinical features suggestive of stroke, it was written past history of stroke in a patient. So it is clinical features where it would be arm weakness, it would be speech impairment, and then for alphabet D, we're gonna use it for duration of symptoms. As I explained to you, in majority of cases, if improvement has to occur, improvement will start occurring majority of cases by the very first hour. So that is why they have again taken this consideration of 10 to 59 minutes. And in case the symptoms are persisting for more than 60 minutes, you can very well see that if the symptoms are persisting for more than 60 minutes, then chances of evolution of TIA and conversion into stroke will be higher. But if the symptoms are showing an improvement, then the chances of conversion into stroke will be substantially relatively lesser. And that alphabet D is also being used for determining whether this person is a diabetic or not. That would be for diabetes mellitus. It is again a single point. The only thing is here in the drop down menu, you will just have to select yes or a no. And let me say if diabetes mellitus is a yes, then again we'll be allocating 1 point for it. The maximum score which is usually possible on the basis of this would be a score of 7. And what I say next is only to make you explain. You don't need to remember the mathematical information. That suppose a total score of 7 is being obtained. What I mean by score of 7 would be, like, let's assume age is more than 60, BP is also increased, 2 points for arm weakness. So like that, we'll have to keep on adding the parameters. So the maximum score is turning out to be, let me say 7. Then I can say that there are 22% chances of development of stroke. And if mathematically I extrapolate 22 to 25, I'm saying for a TIA with a score of 7, 25% chances, actual data is 22 just for mathematical correlation, 25% chances of stroke. It basically means mathematically that for every 4 TIA patients that you're gonna see in your career, one patient can go into stroke. For every 4 TIA patients that you see, mathematically extrapolating the data, one patient can go into development of stroke. So you just need to remember the parameters. Very simple, very easy. Age, blood pressure, clinical manifestations, not past history, duration of symptoms, and diabetes mellitus is ABCD2 score that predicts the chances of development of stroke over not only 48 hours, that's where the highest incidence is, over the next 3 months. Those stroke can occur at any point of time. It could be after 3 months also, but this score is validated at the moment clinically for a duration up to 3 months. Let's now focus on the workup to be done in a case of transient ischemic attack, because in large number of cases the clots could be going from the heart into the brain, cardioembolic. So ECG is being done because I want to rule out the possibility of atrial fibrillation, which is one of the commonest arrhythmias that we encounter in clinical practice. After ECG, another investigation to be done is echocardiography. Ideally, we should be doing both a transthoracic echocardiography as well as a transesophageal echocardiography, because there is a possibility that the clot could be starting from the ventricular chambers as well. The technical term that I'll use for that clot, which is originating from the ventricles, is mural thrombus. And then ECG was done to rule out possibility of atrial fibrillation. As I've explained in the cardiology section, most of the time in atrial fibrillation, there would be presence of left atrial appendage clots, and they are the ones which are, a shower of emboli going into the brain, which is causing these mini stroke manifestations at this particular case or this particular point of time. Now, let's say hypothetically speaking, ECG was normal and echo is also normal, and the relative of this patient is asking you that, sir, you were telling me the clots could be coming from the heart, and if ECG is also normal and echo is also normal, then where are these clots coming from? So I'll tell him that there's another more investigation to be done, because in large number of cases we could be having atherosclerosis of the internal carotid artery, which could be sending a shower of emboli into the brain. So the next test that I'll be doing in this particular case would be a Doppler or a duplex imaging, and this Doppler duplex imaging would help me pick up. The advantage of doing this Doppler duplex imaging would be to pick up the atherosclerosis of the internal carotid artery, because if it's going to be a high grade blockage of the internal carotid artery, if it's going to be high grade stenosis, hemispheric symptoms occurring, then we might have to plan an intervention which is surgical, that is carotid and arterectomy. So the duplex or Doppler, why we are doing it is primarily that I want to basically scan the carotid arteries, and I want to rule out the possibility of atherosclerotic narrowing of the coronary artery, and these atherosclerotic plaques could have fractured, and therefore shower of fragments are going into the brain circulation. If, let me say, all these tests are normal, still no problem, because at least I'll be able to pick up a derangement of lipid profile, because after all, if atherosclerosis at the moment has not caused a narrowing of the carotid artery lumen critical enough to be picked up on Doppler, because Doppler also has limited sensitivity. Suppose it's only a 20% blockage, 30% blockage, then Doppler may not be able to pick it up, but lipid profile is still going to tell me that there is a atherosclerotic process occurring in this case. Along with this, if I do serum homocysteine levels, you know this from cardiology also, that homocysteine basically tells us about premature atherosclerosis. So especially Indian population, doing homocysteine levels makes sense. So that would be a couple of basic baseline workup that should be done in all cases of transient ischemic attack. And even if the workup is not possible right now, we must be starting the patient on low dose aspirin. Antiplatelet drugs must be started in our cases. In fact, nowadays he says that you have to go a little more aggressive, and he recommends the usage of dual antiplatelet therapy. In dual antiplatelet therapy, I will be using 300 milligram of aspirin as a loading dose, and I'll be using 180 milligram of ticagrelor, again loading dose. And from tomorrow, this person will be moving on to 81 milligram of aspirin and 90 milligram of ticagrelor. So the main message is, first day we'll give loading dosage of, they don't ask dosages, so don't bother about it. But what I'm telling you is, we give a 300 milligram loading dose of aspirin, 180 milligram loading dose of ticagrelor. And the advantage of using dual antiplatelet drugs, which are currently recommended for at least next 3 to 4 weeks, that is 21 to 30 days. And after 30 days, he says, because if you're using too much of antiplatelet drugs, there is the risk of GI bleeding also. So followed by this, you will be going in for monotherapy. By monotherapy, majority of cases, we'll continue with the enteric coated aspirin, but initially for the first 1 month after a TIA event. If this very month person has suffered from a TIA attack, Then for the next 1 month, he should be on dual antiplatelet therapy. And considering that there's going to be a risk of GI bleed as well, so followed by monotherapy with aspirin 81 milligram or 75 milligram, whichever baby tablet of aspirin. Baby is a casual word that I'm saying. I mean, for the lower strength aspirin, the enteric-coated tablet that we are giving to this patient to prevent the redevelopment of such an event again and conversion into stroke. Then we need to go in for blood pressure control, because hypertension is one of the most important risk factors for by reading hypertension. Please do not be under an impression that it's always going to cause a hemorrhagic stroke. Hypertensive patients can develop a ischemic stroke as well. So blood pressure control would be required. And well, what are the drugs that are available? So we'll be using ACE inhibitors. And a very interesting entry here. Traditionally, I mean, I've always focused on ACE inhibitors and calcium channel blockers. But here I'm saying that even diuretics have shown a role, especially from neurological prognosis. I mean, normally always bad things are told about thiazides. We always say, no, like whenever we talk about diuretics, we talk about thiazides. We say they cause hypokalemia, they cause muscle cramps, they cause hypomagnesemia, they cause metabolic alkalosis. So traditionally, like thiazides are always abused. But they show a benefit, especially with respect to patients of stroke, to prevent. I mean, we are talking about prevention of transient ischemic attack recurrence, and if we can prevent a TIA, prevention of stroke can be occurring as well. So thiazides have a good result with respect to neurological perspective, or patients who had a TIA, to prevent a recurrence. Then cholesterol control is of paramount importance, because I want the LDL of this particular chap to be less than 70 milligram. And to achieve that, I will have to give high dose, high intensity statin. High intensity statin implies, because the dosage here matters. So the dosage of atorvastatin would be about 40 to 80 milligrams. Again, don't bother about the dosages that I'm saying. Just remember the word high intensity statins. Like we were using high intensity statins in myocardial infarction, in acute coronary syndrome. Today we are using it in a brain attack as well, to stabilize the atherosclerotic plaque and prevent further deterioration. Then carotid endarterectomy and arterectomy, in those cases where there would be high grade stenosis of internal carotid artery documented by a Doppler, and there has been recent hemispheric symptoms, because ICA is the main blood vessel that would be bifurcating and producing AC and MCA, so hemispheric, more aggressive symptoms, and the hospital is having a good experience also. Low institutional morbidity and mortality, kept to less than 6%, then carotid endarterectomy can be done. Diabetes mellitus control has to be established. Diabetes is again an important atherosclerotic risk factor that contributes to not only risk of MI, triple vessel disease, but even a risk of development of stroke as well. And then comes one of the very important agents, that is, if we are able to document atrial fibrillation. In a large number of cases, it would be atrial fibrillation, which would be responsible for clots in the left atrial appendage. Clots are going up in the brain, and therefore we'll be using the newer oral anti-clotting agents, which are called as NOACs or DOACs. One of the important drug that is written is X, that is apixaban, which acts by inhibiting factor 10. So we can be using either apixaban or we can be using rivaroxaban. They also talk about use of dabigatran. At the moment, just for the sake of a mnemonic, I've mentioned ABCDX. Like I was teaching you, ABCD2 score is used to predict the chances of development of conversion of TIA into stroke. Right now, I have taught you that ABCDX is the management algorithm. A would be antiplatelets, blood pressure control, cholesterol control, diabetes mellitus management, and then X here is implying usage of molecules like apixaban, especially in a setting of non-valvular atrial fibrillation. He will use words like NVAF, that means non-valvular atrial fibrillation. Mostly in Western setup, it is non-valvular atrial fibrillation. For atrial fibrillation, there is a special score that is used. That special score is called as CHAD S2 VASC score, that has been discussed with respect to cardiology, where I've talked about the section where I've talked about atrial fibrillation and atrial flutter. And if the CHAD S2 VASC score of a person is more than 2, that is when apixaban needs to be started. If the score is on the lower side, he says we can be using aspirin and ticagrelor. If it is higher than 2, that is when apixaban. I mean, the indication why and when would you be starting it? You need to demonstrate atrial fibrillation, and you need to use a special score. If the score is at a value higher than this, that is when the newer oral anti-clotting agents can be started. Now, specifically from Indian perspective, if we are having a patient who's having rheumatic heart disease, and that this rheumatic heart disease suffered from mitral stenosis, and mitral stenosis will cause damage to the left atrial appendage. The structural damage to the left atrial appendage will trigger a atrial fibrillation. So this time I can use the word valvular atrial fibrillation. Like in the previous slide, I was talking about American patient with, let me say, dilated cardiomyopathy having atrial fibrillation. That's non-valvular atrial fibrillation. Now I'm talking about the Indian perspective, rheumatic heart disease with MS with atrial fibrillation, that is valvular atrial fibrillation. In this particular case, if he says, what are you gonna use to prevent the development of a recurrence, then your answer would be used as or given as warfarin. So please pay attention to this fact, specifically from the Indian perspective. If he mentions rheumatic fever, mentions about mitral stenosis, and then talks about atrial fibrillation, it is warfarin to be answered. If it is non-valvular atrial fibrillation, in those circumstances, it would be standard apixaban, rivaroxaban, that should be answered. Another indication for using warfarin would be when person due to severe mitral stenosis was having so much of damage that valve repair or valvotomy could not be done. If valvotomy as a procedure cannot be done, then we'll have to change the heart valve. That is, a mechanical heart valve was deployed. Let me just explain the prognosis once again. You are aware that mitral stenosis progresses from mild, moderate, severe. If you have a severe mitral stenosis, your approach is to go ahead and do a percutaneous mitral balloon valvotomy. And the problem is, if a severe mitral stenosis is not treated on time, then there can be calcification developing in a valve. If there's a calcification in a heart valve, and if you try to dilate it with help of a balloon, the valve will break into pieces, like a biscuit will break into pieces, and all those fragments will go in the brain. So for severe mitral stenosis with calcification, do not answer balloon valvotomy. I repeat my statement. For severe mitral stenosis, I've explained that in cardiology, guys, but I'm doing an effort here to explain the same thing as well. For severe variety of mitral stenosis, we're going to do a percutaneous mitral balloon valvotomy. Cool. But if it is a severe mitral stenosis with calcification, then we do not answer valvotomy, because the valve will fracture into pieces, fragments will go in the brain. Instead of that, we'll have to change the heart valve and put in an artificial heart valve, that is a mechanical heart valve. And people who are having a mechanical heart valve in place need to be put on warfarin. So I've explained indications when you will be using warfarin to prevent the development of transient ischemic attack and prevent a subsequent episode of development of stroke. Here, it will also give a leverage to the examiner to ask you with respect to what will be the target international normalized ratio. Then, in a setting of mechanical heart valves with the left atrial appendage, the target INR will be one of the highest values that you will read, between 2.5 to 3.5. Now, what is the trick in the MCQ? The trick in the MCQ is, if he says that for mechanical heart valve, mitral valve, or aortic valve that were put, and he does not talk about left atrial enlargement, this left atrial enlargement word is not given, and he says what is the target INR, then your value will be between 2 to 3. I repeat once again, if the data is like this, left atrial enlargement present and a mechanical mitral or aortic valve is put, in a setting of LA enlargement, the target INR will be kept between 2.5 to 3.5. On the other hand, specifically if he mentions that there is a mechanical heart valve deployed, but there is no left atrial appendage, then the target value for us is going to change. The target value will be answered between 2.0 to 3.0. In fact, this 3.5 is one of the highest INRs that you would be deciding to tolerate, considering the high risk of development of cardioembolic stroke in these patients subsequently. We are going to now focus on scenario number 2. The scenario number 2 that I'll describe before you is for acute ischemic stroke, where there's again a 60-year-old man with standard atherosclerotic risk factors like hypertension, diabetes, cigarette smoking. He has a good habit of going for a morning walk every day. And just like any other day, he got up at 6 a.m. in the morning, he brushed his teeth, and then his wife also got up at that point of time, and she was making a cup of tea for him. And meanwhile, he got ready for his walk, he put on his sports shoes, and his wife at that point of time was talking with him as well, routine husband wife chit chat, and she had fixed him a cup of tea as well. At 6:30 in the morning, the wife notices that he has not gone for his standard morning walk. So out of just curiosity, she said, "You did not go for a walk today?" And meanwhile, from the corner of her eye, she did notice that, the cup of tea is empty. So she just came to pick up that cup of tea, and she thought that he'll get up and go for his standard morning walk. And what she's noticing is that this 60-year-old gentleman is, his lips are quivering. He's trying to speak, but no voice is coming out. So his wife is saying that everything was fine. I mean, he was talking to me just a few minutes ago. We were making some plan to go to some religious temple. We were planning to go to Kedarnath, Badrinath, as senior citizens would be planning. And she says, I got the shock of my life when I found that he looked a little dazed, and he was trying to speak, but no voice was coming out. There was a sudden onset aphasia. So she says, I got very panicked. And, from a non medical perspective, if somebody is sick in the family, what do? You just pour water into a glass and try to hand it over to that person and say, okay, drink water. Meanwhile, I'll get some medical aid. And she says that I noticed that he was struggling. His one arm, let me say, if it's gonna be the involvement of the left brain circulation, then the right arm weakness would also come in. So she's also saying that there was a sudden onset aphasia and he was struggling. Like, he's a right-handed person. If you offer a glass of water to somebody and he's a right-handed person, you expect that person to raise his right arm and grab it. But she says, like, he was struggling. He was trying to use his left arm, but there was a significant right arm weakness. She says, like, the one arm was hanging by one side of the body. And then she also says, when I looked at his face, I got the fright of my life, because it was like, the face deviation was coming in. There was a very characteristic facial droop. So symptoms have been noticed by the wife at 6:30 a.m. in the morning. This is not a wake up stroke. A lot of strokes in India may be wake up strokes as well, where we would not be able to do much because we don't know at what time the stroke occurred in an individual, and therefore the window period for thrombolysis might have been crossed. Like, a person went to sleep at 10:30 in the night, and the wife or husband, husband found wife having all these manifestations when they woke up in the morning at 7. Then we don't know at what point of time stroke had occurred, though we do have radiological tests by which we can estimate, okay, what is the approximate time by which stroke could have occurred. But traditionally, in a wake up stroke, the only problem is it's difficult to determine at what time did stroke occur, and the person might be through with the window period as well. In this particular case, however, the person is not having a wake up stroke. He got up, he got ready, he put on his sport shoes, he even drank a cup of tea. And following that, the wife found him struggling. And that is when she has discovered that he's having some features which she does not understand. And they decided to call the hospital. And you can notice this image also showing very characteristic facial droop. Now, this couple has reached the hospital, and you are the one who's called in for acute stroke consultation. So, the first step that you'll be following is a standard norm for any neurology case. That is, you're going to assess the airway. Well, that's important because in a setting of raised ICP, GCS can go less than 8, and that is when intubation is required. Then you need to check the blood pressure of a patient. The reason for checking the blood pressure, once again, maybe the nurse might have taken it, is to only document that in a setting of high blood pressure, you cannot do thrombolysis. Like, suppose it turns out to be acute ischemic stroke. If the blood pressure is more than 185 by 110 millimeter of mercury, then thrombolysis cannot be done. You first have to lower the BP using drugs like labetalol or esmolol, and only then thrombolysis can be safely done, because in a setting of high blood pressure, if you do thrombolysis, the bleeding risk is amplified. For the next step, you might have to call in a sensible relative, because let me say the wife is now emotionally disturbed and she's continuously crying, or she's giving an approximate answer. Then you might have to call in a teenage son or a daughter to find out that when their dad was last seen normal. So next thing that I'm writing is time when the patient was last seen normal. And that's important because I was explaining that if a person had a wake up stroke, like person went to bed at 10 p.m. in the night, he might have had a stroke at 12 in the morning, he might have had a stroke at 2 o'clock in the morning, and he woke up at 8 a.m. or 9 a.m. with features of stroke. Then I don't know at what time stroke has occurred in a person. In those circumstances, the patient is already out of the window period, because window period for acute ischemic stroke for thrombolysis is 4.5 hours only, upper limit is 6 hours only. So I would not like to waste my resources, which is why it is always important that you take help of a relative who did find or who can tell you with accuracy when the patient was last seen normal. Now I will confirm the diagnosis of stroke. Earlier it was suspected stroke. Now I'm going to use a National Institute of Health stroke scale. In this, in the drop down menu, I will have to select various parameters like arm weakness, leg weakness, speech impairment in a person. And if the National Institute of Stroke Health scale value turns out to be more than 5, it is a confirmed diagnosis of stroke. And now I will be doing neuroimaging to find out the etiology of stroke. I mean, the logic behind doing neuroimaging is that I want to find out whether it is going to be a hemorrhagic stroke or whether it's going to be a acute ischemic stroke. In 90% of cases, it's going to be acute ischemic stroke. In 10% of cases, it's going to be brain hemorrhage. So we need to do a CT scan and he will ask you door to imaging time. This door to imaging time should be known to you even without looking at the notes. They give you printed notes, that's okay. But even in your medical college, when they teach you the American Stroke Association protocol, they say you need to be fast with respect to neuroimaging, and we should be doing neuroimaging within 25 minutes. In this 25 minutes, you need to take care of the basic parameters, the vitals of a patient, document that there is a stroke clinically, and then within 25 minutes, neuroimaging should be done. Interpretation should preferably be done within 45 minutes. And let's say the report is saying that there is no evidence of hemorrhage and patient has presented within 6 hours of symptom onset. Like the patient had come at 7:30 in our case and he had symptoms at 6:30, so was presented as early as within 1 hour of symptom onset. CT scan is not showing any evidence of hemorrhage. As I have explained to you, the reason why we do a CT scan is not to currently document a hypodensity. There would be none. It's rather to rule out hemorrhagic stroke, which is a contraindication for thrombolysis. And once I document there is no evidence of hemorrhage, I am saying that I'm dealing with a case of acute ischemic stroke. And now I'm dividing the discussion into two parts. One is that my patient is eligible for thrombolysis. In some circumstances, however, there might be a contraindication to thrombolysis as well. Like I'll be teaching you these contraindications for thrombolysis as well. One of them, the best one I can say at the moment, is bleeding diathesis. If international normalized ratio is already prolonged, it is 3.0, it's 4.0. If there is a documented warfarin toxicity, then person will not be eligible for thrombolysis, which is the reason why I have subdivided the discussion into two parts. Let's look at what are we going to do in each of these arms. If the patient is eligible for thrombolysis, his INR is normal, his age is more than 18, there's a documentation of stroke which is suspected stroke, then clinically confirmed stroke, then etiologically acute ischemic stroke, then thrombolysis is on, and there are two approaches or two drugs that I can be using. Either I can be using a plasminogen activator like tenecteplase, or I can be using elteplase. And the current edition of Harrison says that tenecteplase can be given, in fact, in the CT scanner itself. Like if we are documenting that our patient is having acute ischemic stroke, then subsequently a bolus fibrinolytic drug like tenecteplase can be given. Elteplase can be given, 10% of elteplase dose can be given in the form of a bolus, and the remaining part would be given then subsequently in the form of an infusion. In fact, in a recent FMG exam, they did ask about the dose of elteplase that should be given as a bolus. So elteplase is usually given in a dose of 0.9 milligram per kilogram body weight. The vein of the patient was given to be 70 milligrams. So the total dose that I need to administer would be 70 into 9. That would be about 63 milligram. The question was not regarding the total dose. He said how much of this would be given in the form of a bolus. So bolus would be about 10%. That would be about 6.3 milligrams. So I'm just rounding it out to 6 milligrams. That would be given as a bolus. And whatever is the remaining value, 63 minus 6, that would be given in the form of an infusion. I agree it was really a difficult question that they should not be asking dosages of drugs. But that is what happened in an FMG exam. They were maybe trying to take out some, past enmity with these young doctors, and that is why they asked how much is, of all the things they asked, not even the total dose. They asked bolus dose of the fibrinolytic drug that needs to be given in a case of acute ischemic stroke. But this was one of MCQ. There are gonna be some bouncers in the exam, so don't bother about them. And we come back to our original flowchart. If a person is eligible for thrombolysis, we are gonna do thrombolysis. Once thrombolysis has been done, then we are going to perform a CT angiography. Now, why are we going to do a CT angiography? Because I want to prove that there is a resolution. In majority of cases, the CT angiography will reveal that there is a resolution of obstruction in a particular blood vessel, and which blood vessel it's going to be. I clinically anyway know it's most of the time going to be middle cerebral artery, but now CT angiography will tell me regarding resolution. In some cases, however, unfortunately, there can be a failure of thrombolysis as well. There might be a failure of relief of occlusion, like there was a failure of resolution of a LVO. LVO basically means a large vessel occlusion that would not be opened up. Then what is the approach that will be followed will be told to you in about few seconds from now. Moving to the right side of the forearm, If the question says patient is not eligible for thrombolysis, like for example, I said patient is having a bleeding diathesis, his prothrombin time is grossly diminished, and he says what is the next best investigation to be done, then I'll say we will be doing a CT angiography, and the CT angiography will be in a position to tell me which blood vessel is involved. That is, it can tell me whether it is M1 segment, whether it is M2 segment of middle cerebral artery, is it internal carotid artery occlusion, is it a basilar artery occlusion. So CT angiography can tell me exactly whichever blood vessel is blocked, and then based on whichever blood vessel that is blocked, we're going to take up the patient in the cath lab, and we are going to enter into that blood vessel, catch hold of the clot in one piece and remove that clot. And that procedure that we're going to do is called as thrombectomy. I mean, groundbreaking data, no? If you're not able to destroy a clot by drugs, you can go in for what? Thrombectomy. And thrombectomy will also be done in those cases who are not candidates for thrombolysis. Like if somebody is having high BP and his BP is not coming down with antihypertensive medication, you have given labetalol to this patient to the maximum dose, and BP is still 220 by 130. I'm not going to take a risk with thrombolysis. I'm going to take up the patient in the cath lab. I'm going to do a thrombectomy. But before doing a thrombectomy, what is the step to be done is CT angiography. So pay attention to the words here carefully. This is the algorithm that is given in the current edition of Harrison, where he mentions that if a person is eligible for thrombolysis, cool, you do a thrombolysis, following which you can do a CT angiography to document either there can be a resolution. But if there is a failure of resolution of a large vessel occlusion, LVO stands for large vessel occlusion. If the vessel is not opening up by medicines, no problems. We are having a failure of thrombolysis. We still take up the patient in the cath lab and do a thrombectomy. So there are two indications for thrombectomy that you know at the moment. Let's revise them once again. When do you do thrombectomy? In those patients who are not a candidate for thrombolysis. When do you do a thrombectomy? Those where there is a failure of thrombolysis. These are the two indications that I've explained, and the role of CT angiography in this algorithm is also to be remembered. Coming to version 2 of the same MCQ, patient could have presented to us between 6 to 24 hours of symptom onset. CT scan is not showing any evidence of hemorrhage, and he says what is to be done. So my answer will be I'll be doing a CT angiography, CT perfusion study. This would help us determine that okay, there is going to be a benefit of thrombolysis, there is going to be a favorable perfusion, and the CT angiography report is also going to show us the evidence of large vessel occlusion. It could be occlusion of the M1, M2 segments of middle cerebral artery, or it can show up occlusion of internal carotid, it can show up occlusion of the basilar artery. So we can have a real-time evidence of how much is the magnitude of damage in the brain with respect to perfusion study. I mean, it can pick up the umbra and the penumbra, and CT angiography will tell us which blood vessel is blocked. And then all we need to do is take up the patient in the cath lab. Then we take a vascular access, we go retrogradely via the aorta of this person into the internal carotid artery and then into the brain blood vessel, whichever is blocked. And I know in advance only which blood vessel to go into because I have already done CT angiography, and then we'll be doing a thrombectomy. So that's the third indication for thrombectomy that you need to remember. Now you're aware of the fact that thrombectomy is done in the first 6 hours of thrombolysis and can be done after 6 to 24 hours of thrombolysis as well, which is why now most of the time neurology cath labs are being set up in all tertiary care hospitals so that we can manage acute ischemic stroke and achieve a good neurological outcome. Let's do a quick revision here. Next 15 seconds into what is the indication for thrombectomy. Any case of acute ischemic stroke, if he presents between 6 to 24 hours of symptom onset, any case of AIS, he might write cardioembolic stroke, that is the etiology behind it. I'll in the subsequent slides explain the various reasons why acute ischemic stroke can develop, but 90% cases are those of acute ischemic stroke, and this would be an easy MCQ 6 to 24 hours. Here there is no bifurcation present. But there was a bifurcation that we'll try to remember once again, which is that if a patient comes within the first 6 hours, if we can do a thrombolysis, cool. If we cannot do a thrombolysis, we do a thrombectomy. And if we do a thrombolysis and it fails, we still do a thrombectomy. So by this, I hope I've been able to cement this data into your brain for when are the situations when we would proceed with thrombectomy for a case of acute ischemic stroke. Next up are indications for thrombolysis. There are 4 of them. First and foremost would be that there should be clinical confirmation of diagnosis of stroke, and this would be based on a validated score, that is NIHSS stroke score value of more than 5. The patient's age should be that of consent, that is more than 18 years of age. The third prerequisite would be that the person should be in the window period, As I've explained to you, we have expanded this window period to give benefit to max number of cases. So we can do it up to 6 hours, but best neurological outcomes are seen within the first 4.5 hours. And then the fourth one, I've already written 2 times on the previous slide, that the CT scan should be showing no evidence of any edema. There should be no evidence of any hemorrhage documented on a CT scan. And why that is important is primarily because of the fact that brain hemorrhage is a contraindication for doing thrombolysis. So the complete statement would be CT scan shows no evidence of any edema or hemorrhage for more than one third of the MCA territory. You see, if a person is having a large stroke, which is most of the time spanning over more than one lobes of the brain, if it's gonna be like a hemispheric stroke, then it has a high chances of hemorrhagic transformation. I mean, why we would not like to do thrombolysis in a patient where the stroke is so large that the hypodensity is spanning temporal lobe as well as occipital lobe, that there is a risk for hemorrhagic transformation. So considering that there will be hemorrhagic transformation if I do thrombolysis, that risk of hemorrhagic transformation will be increased. We will next focus on what are the contraindications for thrombolysis, and for this I would like you to remember a mnemonic by the name of STORM. This is again one of the most important slides. In fact, I'll just go back and highlight two must-know slides for you in this particular. Or if you say that I have to revise the topic of stroke, what slide among all the ones that you're discussing is a must-know for me, then this slide that is currently on the focus, this should be like imprinted into your brain, because most cases that are given in the exam in the previous years are for within the first 6 hours of symptom onset, and you have to select whether person is eligible or is not eligible for stroke. What I mean by non-eligible for stroke, which means that you will be doing a CT angiography and then do a thrombectomy, that would be picked up by STORM. By STORM, I mean alphabet S implies that there would be a sustained blood pressure elevation. The cutoff that is to be remembered for this sustained blood pressure elevation is more than 185 by 110 millimeters of mercury. And now pay even more attention to the next few words that I say. He says sustained BP elevation despite treatment. So if with treatment, if you are able to lower the BP to values less than 6, less than the cutoff values that I mentioned, cool. But if in spite of max usage of medication, the BP is elevated, it's 200 by 120 or any outrageously high values, in spite of giving medication, then I'm not going to do a thrombolysis and use an alternative strategy of doing a mechanical thrombectomy. The next thing to be remembered would be alphabet T. That alphabet T can be picked up from the word bleeding diathesis. So in bleeding diathesis, the alphabet T is what I'm writing in capital. Bleeding diathesis technically implies international normalized ratio values more than 1.7. Though, I mean, he may not write that absolute value of international normalized ratios. Most of the time, bleeding tendency would be described. Then alphabet O would be O of gastrointestinal bleeding. If a person is having any reason for GI bleed, it could be ranging from hematemesis due to portal hypertension, hematemesis due to peptic ulcer. I mean, especially in a setting of a peptic ulcer and we have done thrombolysis, then the bleed can be fairly catastrophic. So if a person has had a GI bleed in the last 3 weeks, that is last 21 days, that is a big no to performing thrombolysis. Alphabet R is the easiest one for them to remember. One would be recent head injury, because he might have bled and now the thrombolysis part will increase or amplify that bleed. Or person might had a recent brain hemorrhage. The logic is, if somebody had a brain hemorrhage and luckily survived, and now you are doing thrombolysis in this guy, then this bleed might start once again, and that's the reason why we would not be comfortable doing it. An alternative strategy is available in the form of a thrombectomy. Alphabet MI would be, M would be for recent MI, because most patients who have had a recent MI might be on antithrombotic drugs, and if they are on antithrombotic drugs, they automatically go into that state where their INR is deranged, and in the setting of a deranged INR, doing thrombolysis would be a disaster in making. Alphabet M is also to be used to remember any major surgery which has been conducted on this patient in the last 14 days. So if you focus on STORM, I'll make you practice once again, and then you will only be left between remembering 21 and 14. Alphabet S is for sustained elevation of blood pressure to a value despite treatment. Don't miss this word. If with treatment it is coming down, then we will proceed with thrombolysis. Then is bleeding diathesis, value of INR more than 1.7. O is for gastrointestinal bleeding, alphabet R is coming 2 times, that's the easiest one, recent head injury, recent intracranial hemorrhage, and M would be for a myocardial infarction or a major surgery. And once you get the storm right imprinted in your brain, then in the 21 days is for the GI bleeding part, and major surgery would be for 14 days. In fact, gastrointestinal bleeding, it's a little longer it's taking longer space to write. So that's why 21 days, and major surgery is a little cropped up. So 14 days. That would be one hack to remember this. And we need to now secure 2 IV lines and start IV plasminogen activator, that is either tenecteplase or elteplase. We have to review eligibility before giving it. BP monitoring is of paramount importance. There is no antithrombotics to be used in next 48 hours, otherwise bleeding would be very bad. We have to check for any neurostatus decline. If there is a neurostatus decline, if he says in the MCQ that this person's neurological status is deteriorating, that means that there is starting of bleeding in the brain due to thrombolysis that you have done, and in those circumstances you will have to go in and cryoprecipitate to the patient. Cryoprecipitate is one of the richest sources of clotting factors, and you have to re-image the patient to see whether the patient's neurological status, he's already started bleeding, so first you need to document there is a bleeding, and second you need to document that it's not increasing further. So you might have to re-image the patient more than once, but then the main aspect would be cryoprecipitate administration. And considering the risk of bleeding is present in these patients, he says avoid urethral, you can put a condom cath and avoid urethral catheterization in this patient for the next 2 hours. Next, I'll describe 6 broad categories to improve stroke outcome. First would be medical support, where I'll talk about control of fever, maintenance of blood sugar values, and then more importantly, control of blood pressure. Point number 2 has already been discussed. I have already discussed indications and contraindications for thrombolysis, and then I've also talked about thrombectomy, which would be required in cases between 6 to 24 hours of symptom presentation. Antithrombotics, well, low molecular weight heparin will be required in our cases because the patient will remain bedridden. Because of this bedridden state, he can develop deep vein thrombosis and a catastrophic event like pulmonary embolism. So we need to start antithrombotics in our case. Along with that, we might even be requiring to start low dose aspirin. The reason for that is we want to go ahead with secondary prevention of stroke. He's already had one acute ischemic stroke event. We want to prevent a second one from happening, which is why low dose aspirin needs to be started. But both of these molecules cannot be started in the first 24 hours, considering the fact that our patient might have been thrombolized, and therefore both of these molecules, that is low molecular weight heparin and aspirin low dose, would be started after 24 hours. It depends on the physician's decision. Sometimes might be started after 48 hours as well. Then from the neuroprotection perspective, I'm talking about therapeutic hypothermia, where they decrease the temperature of the brain. If you decrease the metabolism of the neurons by decreasing the temperature of the brain, then the cells are able to survive the crisis. They are able to tide over the crisis relatively better. So this is a FDA approved technique, that is therapeutic hypothermia. And while writing it, I can give example of a Formula 1 driver, Michael Schumacher. He had a nasty crash. But in spite of he having this intensive head injury, they were still able to save him. It's been 6 years since that nasty crash, but Michael Schumacher is still alive thanks to this technique that was used, therapeutic hypothermia. And then a lot of cases of acute ischemic stroke can suffer from malignant cerebral edema. For management of this condition, malignant cerebral edema, as the name suggests, it's going to be serious. So we might have to go ahead with mannitol. But if mannitol will not work, we might be using ventriculostomy, and in some cases, patient may even be requiring, I'm saying even be requiring, a craniotomy as well. Then the most neglected part of management of stroke, because we tend to focus on intensive care, is the rehabilitation part. And in rehabilitation part, one of the strategies that has been shown to cause an improvement would be called as CMT, that is constrained movement therapy. Meaning the word constrained movement therapy is, let me say hypothetically, if my left arm is affected by stroke, so I will have a tendency to use my right arm and I'll try to do maximum of my chores with right arm. What they say in constrained movement therapy is that you have to immobilize, not the affected arm. You have to immobilize the normal arm, like the person's left hand is affected by stroke. So in the patient, what you'll do is you'll strap the right arm, and that's gonna force the brain, because the right arm is now constrained, so it will force the brain and the neural connections to develop over a period of time so that movement can start in the affected arm. So constrained movement therapy does not mean that you are doing immobilization of the affected arm. Constrained movement therapy means, as I explained, we are doing immobilization of the unaffected arm, and our brain has a lot of neuroplasticity. So new neural connections will develop, and as a result of it, the affected arm movement can start. So physiotherapy plays an important role with respect to the rehab component. And out of the 6 points, medical support is important. So in medical support, what are we gonna do? We're going to put pneumatic compression stockings in our case, again to prevent chances of deep vein thrombosis, and similarly antithrombotic drugs would also be required. The antithrombotic drugs, as discussed earlier, will be started after 24 hours only and not in the first 24 hours due to risk of bleeding. As far as blood pressure control is required, though I've already mentioned the values before you, I would just like to subdivide the discussion into two parts. If he mentions that the patient is not a candidate for thrombolysis, like a lots of time person may not be a candidate for thrombolysis, then we need to lower the BP, because if you lower the BP, the rather reverse thing can happen, that is worsening of cerebral infarction will occur, because if you cause a precipitous fall of blood pressure, then brain infarction will worsen. So the cutoff that is required for lowering of blood pressure in case there is no need of thrombolysis would be 220 by 130 millimeter of mercury. That would be malignant hypertension per se. Or if a person is having concomitant myocardial ischemia, then in those circumstances, again, I would like to lower the BP only when the BP is more than 220 by 130 millimeter of mercury. Remember, this data of 220 by 130 is what I have said for a person who is having who is not a candidate for thrombolysis. But suppose a person is a candidate for thrombolysis. Then if he's a thrombolysis candidate, I'm writing a short form T, lysis means thrombolysis candidate. Then the cutoff is what has been discussed in the earlier part of this video also, that is 185 by 110 millimeter of mercury. And that has been determined after clinical trials that if you do thrombolysis at a value higher than this, it can contribute to increased incidence of brain hemorrhage. Then control of fever is important because it will put additional stress on neurons. Control of blood sugar is important. Well, what should be the blood sugar value? That should be maintained in a stroke patient, because a lot of these patients might be diabetics as well. So it is recommended to keep a blood sugar value between 60 to 180, because too high or too low, if I keep it too low or if I keep it too high, it will cause fluid shifts across the brain, and that fluid shifts across the brain can contribute to worsening of cerebral edema. In a large number of cases, we might be having cerebral edema, which might become very extensive. It might cause a midline shift as well. So it would be referred as a malignant cerebral edema. For management of malignant cerebral edema, what I'm going to do, I'm going to try and keep the patient relatively dry. So one of the initial approaches would be answered by you as water restriction. Then we will be using mannitol for management of this cytotoxic cerebral edema. As you're aware, for vasogenic cerebral edema, we answer steroids. For cytotoxic, like stroke causes destruction of neurons, so cytotoxic cerebral edema, will be using mannitol. And then there might be requirement for decompression surgery also, so craniotomy. Now, if the infarct is located in the brainstem, and especially if it is located in the cerebellum, then there is a high incidence of development of midline shift and a brain herniation, because cerebellar infarct will also be associated with development of cerebral edema subsequently. And the cerebral edema, because it's right at the base of the brain, can compress the vital centers. So in those circumstances where there is a cerebellar infarct present, we might have to go ahead with a suboccipital decompression as well. The main point to be understood is that cerebral edema will take about most of the time about 48 hours to appear. So most of the time, though it can appear as late as about 10 days, most of the time the peak of cerebral edema is obtained by 2 to 3 days. So we can have a late neurological deterioration of our case as well, which is why I've delved into medical support. Medical support is, the thought process is that it's only about thrombolysis or it's only about thrombectomy, but you can see what we are trying to discuss here is a more holistic approach to management of our case that is beyond thrombolysis and thrombectomy. All these aspects that I mentioned from point number 1 to point number 5 are also important to improve neurological outcomes. Let us now talk about etiology of ischemic stroke. Why does that happen? In about 30% of cases, no etiology is found. In spite of intensive workup that we do for a case, we are not able to find the etiology. But in about 20% of cases, one of the important cause that is found is cardioembolism. I repeat the fact, lots of time we may draw a blank, like the family member will ask us, why did my father suffer from stroke? And we might not be able to find a cause as well. But in about 20% of cases, we are able to determine cardioembolism. Cardioembolism would mean that in the left side of the heart, there could be damage to the left atria, damage to the left ventricle, damage to the valves on the left hand side of the heart, and therefore these clots which are formed in the left side could disseminate into the systemic circulation, contributing to cerebral embolism. One of the leading causes which should be remembered is atrial fibrillation, which would be written as non-valvular atrial fibrillation. One of the reasons for this non-valvular atrial fibrillation can be cardiomyopathy. I mean, cardiomyopathy of any etiology can trigger atrial fibrillation. In Indian circumstances, obviously, or Indian situation, mostly it's rheumatic heart disease with mitral stenosis that causes left atrial damage and left atrial clots. I've discussed that in mitral stenosis video in cardiology as well. But then I've also explained that in a Western setup, it's most of the time NVAF, that is non-valvular atrial fibrillation. Another possibility is that our patients suffered from myocardial infarction. It was an extensive anterobal MI which resulted in formation of a left ventricular aneurysm. And whenever there's a structural damage to the wall of the heart, there could be clot formation. These clots can disseminate into systemic circulation, causing a cerebral embolism. Another reason to be remembered would be SABE, that is subacute bacterial endocarditis. Again, there are vegetations which are growing on the surface of the heart. They can disseminate into systemic circulation. So both subacute bacterial endocarditis and even Libban-Sachs endocarditis, because even your SLE per se is a hypercoagulable state, plus Libban-Sachs endocarditis, again, the vegetations which are present, the fragments which are present of these vegetations can disseminate into systemic circulation. The next thing that I'm describing is a metallic prosthetic valve. I mean, my patient was having severe mitral stenosis, which was associated with maybe mitral regurgitation, or it was a calcified mitral valve. So I decided to change the mitral valve, and a metallic prosthetic valve will deploy it. And metal and platelets don't go together. So metallic prosthetic valve, whenever is present in a patient, he has to be started on warfarin to reduce the chances of development of stroke. But if they are not taking warfarin on a regular basis, the clots will develop and can go in the brain. So these are like usual the causes for cardioembolism. Then he will come up with a very peculiar statement which is called as paradoxical embolism. Let me explain what I mean by paradoxical embolism. My patient suffered from deep vein thrombosis. So there would be clots developing in the soleal veins, and it can be popliteal vein also, it can be femoral vein also, but ultimately these clots will break down because of activity of protein C, protein S, and antithrombin 3, and I've shown these fragments of clots entering in the right side of the heart. Now, anything that enters in the right side of the heart should be traveling by the tricuspid valve towards the right ventricle and then into the lungs. But in these patients, what is happening is, I'll use a different color to highlight it. In these patients, what is happening is that there is a defect in the interatrial septum, which is causing these small clots to go into the left side of the heart. And from here, they can find their way into the brain circulation. Now, this is very, very peculiar. Why? Or this is a very paradoxical statement, because traditionally, if you are having clots in the right side of the heart, they should go into lungs. But in this patient, because of presence of a patent fossa ovalis, the clots can move on to the left side of the heart and then go into systemic circulation as well. So for point number 2, what you need to remember is this term paradoxical. I mean, why is he calling it paradoxical is what I've tried to explain, that traditionally anything that goes into the right side of the heart should be resulting in development of usually, I mean, the usual manifestations are going to be development of pulmonary embolism, but here it would be a systemic embolism developing. The third reason could be atherosclerosis, internal carotid artery atherosclerosis. Like our patient could be a diabetic. Diabetic patients have one of the highest relative risk for development of stroke. Now listen to my words very, very carefully. If he says what is the common type of strokes that we see, it is ischemic stroke, majority is cardioembolism. For cardioembolism, if he specifies what is the usual reason, your answer for cardioembolism, the usual reason would be, the most common reason would be a valvular. I mean, it could start off as a valvular defect like mitral stenosis, but at the same time, because of the structural damage to the left atria, there could be starting of a abnormal electrical activity, and this could be in the form of atrial fibrillation. The twitching of the atria will cause clots, and the clots are going in the brain. But if he says which condition, listen to the words carefully. Cardioembolism mainly is due to atrial fibrillation. But if he says which condition has the highest relative risk of development of stroke, and in the options he's mentioning risk factors like stroke, like smoking, diabetes, hypertension, then overall the highest relative risk is with diabetes mellitus. Diabetes, guys, is a cause of accelerated atherosclerosis. This exerted atherosclerosis can develop in the internal carotid artery. It can even begin in the proximal part of the middle cerebral artery, and the atherosclerotic plaque which is present there can fracture, and this fragments from the atherosclerotic plaque can then be traveling downstream, resulting in stroke manifestation. So it is not always atrial fibrillation. Lots of time the rhythm will be normal and patient is still having stroke. How do I pick up this internal carotid artery atherosclerotic lesions? I might be having to do carotid artery Doppler, as I explained even in the workup of transient ischemic attack. My objective is to pick up atherosclerotic lesions in internal carotid artery, which could be throwing a shower of emboli into distal circulation, resulting in cardioembolism and ischemic stroke. Then in some cases, they can even be internal carotid artery dissection. The leading cause of aortic dissection is hypertension, and then there's a possibility that the tear can progress antegradely as well as retrogradely. The retrograde tear will be towards, the spread of the tear will be towards coronary arteries, but the forward spread can involve the internal carotid artery, or it can also be a vertebral artery dissection as well. I mean, there could be a posterior circulation stroke developing. So point number 3 and 4 are related to pathology of the internal carotid artery. In fact, if you notice, there are a lot of similarities between what I was saying with TIA workup and currently etiology of ischemic stroke, because TIA is a mini stroke. It's a warning symptom for development of stroke in a patient. So all the risk factors which are responsible for TIA will ultimately or will be responsible for development of stroke as well. And that is why in the workup of TIA, I was emphasizing on performing a carotid artery Doppler to identify the status of internal carotid artery. Lots of time, even the carotid artery might turn out to be normal, but our patient might be having a hypercoagulable state. Now, one of the leading hypercoagulable state is obviously pregnancy, but I'll tend to talk beyond it. Like one of the important hypercoagulable state that we know is called as antiphospholipid syndrome. This has been discussed with the topic of SLE. In antiphospholipid syndrome, we have antibodies, no, like anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody. These antibodies cause intrinsic system of the intrinsic system of clotting to go into automatic mode. I mean, in you and me, when there's a trauma, that is when clotting is occurring. But in these patients, even if there is no trauma, the clotting cycle goes into automatic mode, and that would result in development or triggering of clots. So antiphospholipid antibody syndrome is characterized by intrinsic system of clotting going into automatic mode and triggering of clots, not only in the uterine artery and uterine vein, causing bad obstetric history and recurrent abortions and intrauterine death that you read in gynecology. These patients can have MI also, these patients can have stroke also. Then in this decade, the starting of this decade was with COVID-19 pandemic. So COVID-19, the spike antigen is itself responsible for hypercoagulable state. Then I'll mention some of the common things like homocystinemia. I mean, Indians are anyway predisposed to having hyperhomocystinemia, which predisposes to early onset atherosclerosis. As I've explained, Libman-Sachs endocarditis is also itself a hypercoagulable state. And then is the traditional information. I mean, the conditions where we get increased chances of clotting would be patients having protein C, protein S, and antithrombin 3 deficiency. You're aware that we have clotting system in our body, anti-clotting system. If anti-clotting system is deficient, then clotting cycle will be unopposed, and that unopposed clotting cycle will trigger a clot formation. Or for that matter of fact, I can mention another one that is called as factor 5 Leiden mutation. In factor 5 Leiden mutation, factor 5 keeps activity of protein C under check. Factor 5 and protein C, they balance each other's activity. Factor 5 is pro-clotting, and protein C would be anti-clotting. So there's a balance always present. And if there's a defective interaction between the two, then factor 5 activity will be unopposed, and that can again trigger clot formation. So these are a couple of hypercoagulable states which are responsible for development of ischemic stroke. 90% of cases that we see in our clinical practice are those of AIS, and the remaining cases would be that of remaining data would be that of hemorrhagic stroke. In some books, the percentage might be given a little different, like it's given in a range 80 to 90%. So I mentioned the data on the higher side of normal, and the remaining cases would be with respect to ischemic stroke in comparison to hemorrhagic. I mean, the percent is 10%. And here I just want to emphasize that once again, on reading the word hypertension, don't be under impression that he's always going to talk about hemorrhagic stroke. Because we agree that hypertensive crisis is going to be responsible for brain hemorrhage. That's understandable. But on reading the word hypertension, I cannot predict. It's a CT scan that would be telling me whether I'm dealing with a ischemic stroke or whether I'm dealing with a hemorrhagic stroke. So let's look at a couple of miscellaneous data here. And that would make this discussion even more interesting, because lots of time you will read in medical college terms like cortical, subcortical, and brainstem stroke. So whenever there's a cortical stroke happening, the question will always mention a couple of A's present, like there would be aphasia, or there might be apraxia or agnosia. So a lot of A's will be described in a question that I've described with respect to, even in the earlier part of the video on stroke, where I've talked about parietal lobe, temporal lobe lesions per se. I've described a couple of manifestations. So a lot of A's would be given, but none of those A's would be described with respect to subcortical stroke. Another feature that you will notice in cortical stroke would be, like, suppose the right middle cerebral artery will get occluded, then both eyes of the patient will be looking towards the side of the lesion. In cortical stroke, you will always notice patient looks towards the lesion, or in some MCQs, he might deliberately write a different term. He might say patient looks away from the side of weakness, because if it's the right artery that's occluded, the weakness in the body will be in the left hand side, like left arm weakness. So patient will be looking away from the left arm weakness, or will be looking towards the lesion. So for cortical stroke mainly, I want you to remember patient looks towards the lesion, plus there would be features like A. But when it comes to subcortical stroke, that would be small vessel stroke in a patient that will be taken up subsequently. You will notice that there would be no A's described in a question. He will talk about only pure motor paralysis, or it would be like pure sensory manifestation. So whenever you get pure motor stroke, or you get pure sensory stroke, that is when you read about, or that's when you think in terms of subcortical stroke, where the penetrating branches of the lenticulostriate artery can be involved. Most of the time, he'll put up a question on pure motor stroke, where person would be having contralateral half face, arm, as well as leg paralysis, and the involvement will be of the posterior limb of the internal capsule. I'll speak more about small vessel stroke towards the subsequent later slides, but at the moment, the main message is on a comparison between cortical and subcortical stroke. Subcortical stroke will be having either pure motor or pure sensory manifestations, or there would be no mention of those alphabet A that would be described. And then when it comes to brainstem stroke, person will be looking away from the lesion, and apart from that, there would also be cranial nerve palsies. I mean, those cranial nerve palsies are very characteristic. Like third nerve palsy will contribute to development of ptosis, and there would be drooping of an eyelid. Along with that, the eye would be looking out and laterally. So I have described this in one of the previous videos, where I've described Weber syndrome. I have talked about lateral medullary syndrome. So their cranial nerve palsies have been taken care of. Like in medial medullary syndrome, it's the 12th nerve that's involved, but lateral medullary syndrome, 12th nerve is not involved. So cranial nerve palsy manifestations will be given. And another feature of brainstem stroke would be crossed features. Crossed would mean on whichever side the blood vessel is blocked, on that particular slide cranial nerve palsy will occur. But the hemiplegia will always be on the opposite side. That's traditional. No, corticospinal tract involvement will always result in contralateral hemiplegia, but cranial nerve palsy will be ipsilateral. That is why the word is crossed. So like in lateral medullary syndrome, we say the word crossed hemianesthesia. So though I've described this in the earlier part, I thought I should just mention these terms once again: cortical versus subcortical versus brainstem stroke. And if he puts up a radiology question saying what is best for early identification of acute ischemic stroke, then obviously we will do a CT scan following the American Stroke Association protocol. But on a comparison basis, like, pure radiology based question, because half the time this facility will not be available even in tertiary care hospitals. But suppose I have to select between a CT scan and a contrast in a CT scan, and then a plain MRI and a diffusion weighted MRI, then you have to say diffusion weighted MRI. Diffusion weighted MRI can pick up the damage in acute ischemic stroke within the first hour itself. In contrast, when it comes to a non-contrast CT scan, the hypodensity might be taking a outrageous 6 to 12 hours to appear. So let's look at these images here. I mean, the first image that I am currently showing before you is that the clot has developed in the left middle cerebral artery of this patient. So the technical term that we read is dense MCS sign. The topic that I'm trying to explain to you at the moment is that there's a clot. So that means I'm describing a left-sided acute ischemic stroke. But this finding is again very rare. Lots of time this is like, because we are doing a classical textbook kind of a discussion. That is why I've described a dense MCS sign. In a lot of cases, dense MCS sign may not be seen. But in the same patient, after approximately 6 to 12 hours, you will notice a hypodensity appearing. And as I've explained to you, that we are not going to wait for that hypodensity to appear and then say, okay, I'm dealing with acute ischemic stroke. I've already demonstrated that there is among on clinical grounds on the basis of NIHS score, I have demonstrated that there is a presence of stroke, and neuroimaging is being done mainly to rule out the possibility of hemorrhagic stroke. Nowadays, we can obviously do a CT angiography if required to pick up large vessel stroke, but if it is a small vessel stroke, you would not be able to pick it up on a CT scan, and the manifestations will appear only after 6 to 12 hours. So the main message is, I mean, the query of a lot of people is, sir, you said CT scan is normal, and relatives are arguing, how can you be sure? So can't you do a CT angiography? Yeah, I can do a CT angiography. But then CT angiography also has a limitation, no? It can only pick up a large vessel occlusion, LVO. If it is a small vessel stroke, you still are in a blind. CT scan will not be able to pick it up. And that is why they're saying, no, that ideally you should be investing, a hospital should be investing money in purchasing, they should be having a facility round the clock available for a DW MRI as well, so that ischemic stroke can be picked up early. Then if you look at the images on the contralateral side, you can pick up a hyperdensity present, and this hyperdensity has again been shown on comparison on the left side only. So there are two images that I've currently shown. One is that of ischemic stroke, AIS, and the second one is hemorrhagic stroke. Hemorrhagic stroke is obviously a contraindication for thrombolysis, and the leading site of hemorrhagic stroke is usually the putamen. If he says which blood vessels are usually involved here, then it is the small blood vessels. This guy is usually having hypertension, or he could be having warfarin toxicity, dabigatran toxicity, pixaban toxicity. The blood vessels that are usually affected would be penetrating branches of the lenticulostriate artery. You're aware that lenticulostriate artery is a branch of middle cerebral. It is one of the main branches of middle cerebral artery. But if he says per se that which blood vessel would be affected in a case of hemorrhagic stroke, then your answer would be the technical answer is penetrating branches. Do not answer lenticulostriate. It is the branch of the lenticulostriate artery, those ultra small ones, which are going to be affected in this particular case. And therefore, I've tried to give a distinction between acute ischemic stroke versus hemorrhagic stroke on a CT scan. But as I've explained multiple times, that hemorrhagic stroke manifestations will develop very fast, but ischemic stroke manifestations will take a long time to appear. And therefore, we ideally either should be investing in diffusion weighted MRI or rely on a clinical judgment, rely on NIHSS score values, and then start treating our case of acute ischemic stroke. Next, I'll focus on venous stroke. Let us look at the triggers which are responsible for cerebral venous thrombosis, and lots of them would be having alphabet P present. Like, let me say we started a young lady on oral contraceptive pills. I mean, the gynecologist started a lady on OCP, and unfortunately, we did not know that this lady is having a defect of factor 2. She's having a prothrombin G2021 OA mutation, which is responsible for activation of the clotting cycle and is described as a hypercoagulable state. I mean, the gynecologist was not aware that this person whom OCP is being started is having factor 5 laden mutation or is having G2021 OA mutation. Both of these are hypercoagulable states. Another hypercoagulable state would be antiphospholipid syndrome. The reasons for these have been discussed even today, and even in this particular video, and even in the SLE video as well. Then suppose a person is having sickle cell anemia, then sickled RBCs are sticky RBCs. So at the branching point of any blood vessel, they'll stick to each other and contribute to brain infarction. If a person is having polycythemia vera, or if a person is having secondary polycythemia, the RBC mass will be more. If RBC count is more, RBC mass is more, the circulation will become sluggish, and that sluggish circulation will predispose to thrombosis in the superior sagittal sinus, and that would be then referred as cerebral venous thrombosis. Similarly, any hypercoagulable state, it can be prothrombin G2021 OA mutation, it can be protein C, protein S antithrombin 3 deficiency. And before I write more, I can just once again point to the fact that a lot of them were having alphabet P's present. So lots of time the question will begin by describing a female after pregnancy. Pregnancy itself is a hypercoagulable state, or you can notice the alphabet P coming up at antiphospholipid antibody syndrome, in polycythemia, protein C, protein S deficiency. So these are the usual, any of these background information would be given with respect to venous stroke. Post meningitis or post sinusitis, lots of times sinusitis can then later contribute to meningitis, and meningitis as a CNS infection can cause cerebral venous thrombosis. or it could be a case of severe dehydration. Dehydration will also make the circulation sluggish and predisposes to clot formation in any of the dural venous sinuses. It could be superior sagittal sinus, straight sinus, sigmoid sinus that would be affected. So the question will begin by describing a young female having a sudden onset headache and new onset seizures. Now the query of a lot of people is that why is there a development of seizures in this patient? Well, the logic here is that the veins are ultimately getting obstructed. Like let's say the superior sagittal sinus or any other vein per se, the venous circulation is getting obstructed. So if there is obstruction of any vein, then proximal area, the capillaries, the pressure, hydrostatic pressure will rise. And in the brain, if hydrostatic pressure is rising in the capillary end, then it would result in fluid to move across to the by crossing the blood brain barrier. The fluid will move into the brain tissue, and there would be a development of vasogenic cerebral edema. I'll say this or explain this once again. I said simply that if there's obstruction in any vein, then proximal area pressure will begin to rise. Because of the rise of this pressure, especially in the capillary bed, there would be increased transudation of fluid into the brain tissue, and thereby vasogenic cerebral edema, new onset will develop, and that is why new onset seizures are being described in this case. And sometimes it can also happen that there can be possibility of this rupture of these small blood vessels also, because if there's a venous obstruction, on one hand there is artery, other side there is vein, artery sending blood towards the vein. If vein is obstructed, pressure will keep on rising proximal to wherever the obstruction is, and then you could be having possibly small veins rupturing or capillaries that could be damaged, and thereby even brain hemorrhage can be described or can be seen in patients as cerebral venous thrombosis. It looks surprising because I have written the word thrombosis. So the query of a lot of people is that, sir, on one hand you are saying thrombosis, then why are you saying hemorrhage? Well, all I'm saying is that wherever there is an obstruction proximal to that, the pressure is rising. So that proximal area when the pressure will rise can just pop off, and that is why even brain hemorrhage can occur in these patients. And brain hemorrhage will again irritate the neurons and can explain the new onset seizures and development of a sudden onset arm weakness or a leg weakness. And the reason for raised ICP, well, I can say one, that because in this case there is a venous obstruction, as a result of it, there would be a decreased reabsorption. See, because veins are obstructed, the dural venous sinuses are not functioning properly. So the reabsorption of CSF will be affected. CSF is produced at 20 ml per hour. It is reabsorbed at a rate of 20 ml per hour. If there's a difference between the rate of production and rate of reabsorption, production is occurring okay, but reabsorption is getting hampered, because of which there would be raised ICP, and that will explain the altered mentation. So now it makes more sense. This young lady was started on OCPs, or like she's a known case of antiphospholipid antibody syndrome. She's complaining a severe headache. Initially thought it is migraine, then she started having seizures. Then she started developing arm weakness, and then subsequently there would be altered sensorium, altered mentation developed, because raised ICP contributes to depression of the sensorium of a person. So that would be the usual scenario that would be given. And when we are going to evaluate this particular case, then the imaging modality that would be required would not be a plain CT, or plain CT might even turn out to be normal initially, but we'll be able to demonstrate the occlusion of the venous sinuses by either doing a CT venography or a MR venography. The classical sign you are very much aware of. The classical sign is what is called as empty delta sign. So I'll try to explain that empty delta sign as well. That is seen in this particular image, and what you can see here is a gray area. There is a gray area, and surrounding this gray area there is a contrast enhancement as well. So I'll just explain why in the initial part, in the inside part, I can't draw gray, so I'm drawing it white. But in the inside area, this area is where the blood supply is not there. This is because there is an infarct in the superior sagittal sinus. So as a result of it, the blood supply is not there. So this is a filling defect which is described. What you can see in gray area in the center is what is called as a filling defect. And surrounding this, there would be a lot of inflammation in the wall of the venous sinus. That inflammation in the wall, this inflammation in the wall of the venous sinus would result in contrast enhancement. So there are two things which are being seen, a filling defect and then an area where there's a contrast enhancement. And the combination of the two is what is called as an empty delta sign. Delta would mean something like a triangle only, but then the point is the inside of that will be relatively grayish or blackish because of the filling defect component, and then there's a contrast enhancement in the wall of the sinus which results in this appearance which is referred to as an empty delta sign. For management of venous stroke, we will not be doing thrombolysis. Our answer will be that we'll be putting our patient on heparin, that would be low molecular weight heparin, and then subsequently these patients would be put on oral anti-clotting drugs The duration for which the OAC might be required in these patients can range between 3 to 6 months without watch on the symptoms, because recurrence is very much a possibility due to the fact that a large number of these patients would be having those P conditions, which were pro-thrombotic conditions. So per se, I can say cerebral venous thrombosis question will most of the time first give you a hint with respect to a pro-thrombotic state. Like he begins by saying SLE patient, antiphospholipid antibody syndrome. So you are mentally, adapted to the fact that, okay, that there could be the reason behind that prothrombotic state is the reason behind development of the CNS manifestations. And as I explained, the reason for seizures would be vasogenic cerebral edema due to increased pressure in the capillary head. Then the capillaries can burst, so they can be a bleed as well. And because of decreased reabsorption of the CSF, there would be gradual rise of ICP, so even cranial palsy and altered mentation can be described with respect to venous stroke. Now, recently there was a trend with respect to this moe moe ho gaya, right? But that moe moe was symbolizing or signifying that something bad has happened. But for us doctors, we don't say moe moe, we say moya moya disease. Well, what is moya moya disease? As you can see in this image, there is gonna be an occlusion of a blood vessel, and because of this occlusion, there would be development of collaterals. So, which blood vessel is involved in moya moya disease? Your answer would be internal carotid artery distal part, or it is the start of the middle cerebral artery which would be involved because of this occlusion. And remember, this occlusion in moya moya disease should not be confused with that of Takayasu's disease. Takayasu is an inflammatory occlusion of the ostia of the blood vessels. Like in Takayasu, there is a osteal inflammation, there is aortitis present, and there is a inflammatory narrowing of the ostia of the renal artery or ostia of the left subclavian artery, and therefore unequal pulses can be seen between left and right arm, and later on pulseless disease will develop. But moya moya disease is non-inflammatory occlusion of the distal internal carotid artery and the middle cerebral artery, and because of which there would be formation of collaterals. Now, what is going to be the manifestations in moya moya disease? It would be that of recurrent transient ischemic attacks and even development of ischemic stroke. And later on, these collaterals can burst also. You can notice that even in this line representation, I've tried to show that a couple of these collaterals which are thin walled can rupture, and therefore moya moya disease can result in brain hemorrhage. If you read the literature in textbook, you will notice moya moya disease will be described in literature of both ischemic and hemorrhagic stroke. Why it is described in ischemic stroke? Because there is a narrowing of blood vessels, so ischemic stroke. But at the same time, it is also described in hemorrhagic stroke because these collaterals can burst as well. And that is why this is one peculiar such condition which you will read with respect to both ischemic as well as hemorrhagic stroke. If we do a conventional angiography, in patients of moya moya disease, then these collaterals can be seen in the form of a puff of a smoke, and that is the Japanese word per se. The meaning of the word moya moya would be a puff of smoke that would be seen on angiography. In pediatric age group, the presentation of these cases would be ischemic stroke. In adult age group, when the same patients become adults, because they become adults because collaterals are developing, but later on in adult age group, most of these persons would be having a hemorrhagic event. We'll next focus on CADASIL, that is rather from a pathology perspective. One, they'll ask you about the gene which is involved here, that is called as Notch3 gene, and then we will focus on the full form of it. So AD is understandable, it is autosomal dominant, so there is going to be a positive family history of stroke described, and this person's father or mother might have died at a young age again because of stroke, and even this person will start having features of not one but multiple episodes of stroke. So it is CAD would stand for cerebral autosomal dominant. Then SI would stand for subcortical infarcts, and then subsequently alphabet L is also there, that would be standing for leukoencephalopathy. So let's just practice the tongue twisting terminology at the moment. The terms to be remembered would be cerebral autosomal dominant subcortical infarcts, and along with this there would be a development of leukoencephalopathy as well. Now, the usual age of presentation of CADASIL in a MCQ or in practice would be between 40 to 50 years of age. The initial presentation will be described as migraine with aura, but subsequently these chaps would be having recurrent episodes of stroke. It will begin with transient ischemic attacks or mini strokes, but then the same patient can be having multiple strokes, and he might be lucky enough to survive those events as well. And he will say that even the father or mother of this person expired due to stroke or had a similar kind of presentation. So positive family stroke would be described Autosomal dominant conditions anyway have a tendency of being expressed in every generation. Most of the time, the migraine that is in this condition is with aura. So he'll try to, bluff around by describing features of migraine in the question. But what you have to pick up is the positive family history of stroke and multiple stroke events that this guy has survived and finally will expire because of it. There's a genetic reason behind development of stroke, which has been discussed here, in contrast to moya moya, which is a non-inflammatory occlusion of the distal internal carotid artery. And moya moya basically in Japanese means puff of smoke. We will next talk about PRES, that is posterior reversible encephalopathy syndrome, which is again very common question where we'll again begin by a female patient with development of headache, seizures, and a lot of guys casually read that as possibility of cerebral venous thrombosis. But then there would be some things that were not described with respect to when I was describing cerebral venous thrombosis. I did not talk about blindness and I did not talk about any fluctuation in neurological symptoms. Let me explain what I mean by fluctuation or neurological symptoms. Posterior reversible encephalopathy syndrome, or PRES, basically is a clinico-radiological condition, and that develops because of loss of autoregulation due to a couple of triggers that are described, but loss of autoregulation with respect to the blood supply of the brain. If you have very high blood pressure, then very high blood pressure can cause increased transudation of fluid. I mean, high blood pressure across the capillaries would cause more fluid to leak into the brain tissue, causing a vasogenic cerebral edema, and it can explain the development of seizures. And most of the time in this condition, this cerebral edema is very pronounced in the occipital lobes, because of which the blindness part would also come. So what is the trigger behind development of a posterior reversible encephalopathy syndrome would be very high BP and loss of autoregulation of the brain in the setting of elevated blood pressure. And what are the conditions where we can be getting very high blood pressure? One is obviously the traditional part, eclampsia, because I'm describing a female patient, so I began with eclampsia. Then suppose a person is having acute glomerulonephritis, then acute glomerulonephritis or cricentric glomerulonephritis or rapidly progressive glomerulonephritis can be associated with acute kidney injury. The drop in GFR will cause RAS system activation and therefore a spike of blood pressure can be present. Then can be use of recreational drugs as well. So even I can say methamphetamines, if they are used in very large amount. Methamphetamines are one of the commonly used recreational drugs, and they cause excessive sympathomimetic drive. Like this guy went to a party, he drank 2 Red Bulls, then he had methamphetamine as well, and due to combination of the excessive sympathomimetic stimulation that's coming in due to caffeine also going in, methamphetamines also going in, the drive and the sudden vasoconstriction and the increased blood pressure of this patient will cause loss of autoregulation of the brain blood supply, and therefore vasogenic cerebral edema can be seen in this condition on an MRI. It usually is present in the occipital lobes. That's why the term is posterior. Though it can be present in temporal lobe also, it can be present in frontal lobe. All lobes of the brain can be involved, but usually it begins in the occipital lobe. That is why blindness can be present. That is why the posterior word is used. And if you are going to control the BP, the manifestations are going to dramatically reduce. So you're calling it reversible. I mean, stroke is not going to be reversible, but PRES that we're discussing here is a differential that has to be kept in mind, especially if a question begins by describing a female patient. So, I mean, every time you read about a young lady and she's having features which are suggestive of stroke, then while attempting MCQs, you must take into consideration possibility of a superior sagittal thrombosis, that would be a venous stroke, or a possibility of posterior reversible encephalopathy syndrome. A couple of more triggers can also be present, like he can describe SLE, antiphospholipid antibody syndrome. So, I mean, it will most of the time deal with, like SLE, you are aware, is always associated with kidney damage. Kidney damage always causes high BP. Or if I say scleroderma has scleroderma crisis, again the blood pressure would be high. So high blood pressure is responsible for loss of autoregulation of the brain blood supply, and that's the reason for that vasogenic cerebral edema that is developing. The diagnosis of this condition can only be made if the question mentions concomitant MRI. I mean, the MRI image will be given, and what you are going to be seeing would be a bilateral occipital lobe, though it can even be parietal lobe, it can be temporal lobe, and even a frontal lobe involvement. The cerebral edema involvement will be very characteristically seen as white. The diagnosis of this condition will become very easy for you in multiple choice questions, because anyway the MRI head findings would be given, and what you will be able to see is characteristic whiteness in the occipital lobe, which will be spilling over to involve the parietal lobe, temporal lobe, and even the frontal lobes, as can be seen in this image. and therefore MRI head showing occipital lobe hyperintensity is the best way to crack these questions. In CT scan, we always say the word density, and with MRI, we always say the word hyperintensity. There is no drug or choice for this condition. The main thing would be control of blood pressure. So we have to bring mean arterial pressure of this patient under control. He says usually we need to obtain a mean arterial pressure of about 130 millimeter of mercury. Couple of these patients could also be having status epilepticus. So the algorithm for status epilepticus, where we'll start with diazepam or lorazepam and then add phenytoin, or we might have to give valproate or levetiracetam to these patients as well. So status epilepticus also needs to be managed in this patient on a war footing. But as we gradually control the blood pressure, we'll find that this cerebral edema will tend to disappear, and there can be a possibility of a neurological recovery. Coming towards the end of this video, I'll next talk about small vessel stroke that would be constituting about 20% of all strokes. So let's look at this line diagram here, though this is a repetition, but I would love to do this. Just adjacent to the lateral ventricle, which is currently shown here, is the caudate nucleus. And then what you can see here is the lenticular nucleus, where towards the periphery is the putamen and towards the inside would be globus pallidus. And then separating the two would be an anatomical structure that is now being shown, that is the internal capsule. This internal capsule is the one from where the corticospinal pathway and the corticobulbar fibers will be descending downwards into the brainstem and then towards the spinal cord. And one more structure that I'm currently drawing in yellow here is the thalamus, and thalamus would be the pain relay center in the body. This area that I've currently shown in white and purple and yellow would be innervated by, or would be like the blood supply of this area would be the penetrating branches of the lenticulostriate artery. Now, as I move a little more or zoom into this diagram, I can show that I've shown an anterior limb, and then I've shown a posterior limb, where I'm shading at the movement can be taken as the posterior limb of the internal capsule and the genu. Now, because this is a two-dimensional diagram, so I'm having to draw like this, but I've shown arm of the patient, I've tried to show the legs of the patient and the face. And all I'm saying is that if there's gonna be a bleed with respect to the putamen, as the bleed will increase, let me just hypothetically create a bleed here. So if there's gonna be a bleed developing here, then this bleed, as it will increase in size, it will be contributing to leg paralysis, arm paralysis, and then facial paralysis. So traditionally, they'll ask you regarding pure motor stroke. Pure motor stroke would be where you would be having face paralysis, arm paralysis, and leg paralysis because the bleed has started in the area of the putamen. A CT scan identical to what I just highlighted here was shown even in the earlier part when I was showing you regarding hemorrhagic stroke. There was a hyperdensity present here. So that hyperdensity, though I'm not shown it at the movement because it will destroy the diagram then, but then the point of mine is that as the bleed will increase, it will press on the posterior limb of the internal capsule, resulting in development of a pure motor stroke. Lots of time the question will say lacunar infarction. So what do you mean by lacunar infarction is small vessel stroke only, but that is just to make the question sound more sophisticated. And then he will say that what is the cause for development of this lacunar infarction, and what you have to answer it as not atherosclerosis. Just pay attention to the word. Do not answer atherosclerosis. Atherosclerosis is affecting large blood vessels, and we're talking about penetrating branches of the lenticulostriate artery. So what is present here is atherothrombotic occlusion, or instead of writing atherothrombotic, he might like to use that pure pathology term lipohyalinosis. There is a atherothrombotic / lipohyalinosis which is responsible for occlusion of the ultra small blood vessels. It is responsible for occlusion of the penetrating branches, and that is why the manifestations would occur of small vessel stroke. About 20% cases of stroke, 30% cases, as I said, may not be having an etiology. 20% cases might be cardioembolic, which is due to atrial fibrillation, but in large number of cases, it might be a small vessel stroke as well. The reason for that would be answered by you as lipohyalinosis or occlusion. And usually the trick in the MCQ will be he'll write atherosclerotic narrowing. It is not sclerotic narrowing, as I explained. It is atherothrombotic occlusion of the penetrating branches, which is responsible for the manifestations there. Now, there are 4 of them that we need to remember. There can be pure motor stroke, there can be pure sensory stroke. So, pure motor hemiparesis, he'll usually ask you what is the site of the lesion, and your answer would be the infarct would be developing in the posterior limb of the internal capsule. Though this slide that I'm mentioning might be sounding like a repetition from anatomy as well, but this is subcortical stroke, so I have to anyway talk about it. Pure motor paralysis that occurs as subcortical stroke, small vessel stroke with infarct in the posterior limb of the internal capsule. Then we can be having a pure sensory stroke as well. So if there is going to be a pure sensory stroke, it means that there is going to be involvement of the thalamus. Thalamus is the pain relay center in the body. So your answer is there is an infarct in the ventral part of the thalamus. So do remember that thalamus also has multiple parts, medial, lateral. So we remembering the ventral thalamus. A large number of these patients subsequently can start developing severe, uh, I would say, burning pain or maybe in the leg. So these patients who subsequently, like when the nurse is doing sponging of the body of this patient, like this person suffered from stroke today, and 2 weeks, 3 weeks down the line, the nurse is doing sponging of one half of, like she's doing sponging of the whole body of this person. But when she's doing sponging over one particular side where the stroke has occurred, then this person is wincing in pain. Though she is doing sponging with temperature, with water which is of like, let me say temperature is 37 degree or it's slightly warm, it's not burning hot, but person is experiencing pain as if like the body is being immersed in acid, or the body is being immersed in burning water. So that manifestation where a person's post involvement of the ventral thalamus suffers from burning pain in the hand or in the half of the body is called as Dejerin-Roussy syndrome. And for Dejerin-Roussy syndrome, you will notice that painkillers will not work. So you'll have to use gabapentin, you'll have to use pregabalin, amitriptyline. You might even have to use cannabinoids for management of this condition. Dejerin-Roussy syndrome will be having neuropathic pain. And neuropathic pain, as you're aware, will not respond to traditional painkillers. It would be extreme burning pain, like as if person's body is being immersed in burning water or like scalding water or like being immersed in acid. Then comes a very peculiar manifestation on which I get a lot of queries: ataxic hemiparesis. You see, in stroke we have hemiparesis. The query is why there is a ataxia also present. The reason for that is that also traversing through the internal capsule, is corticopontocerebellar tract, and because of the damage to this corticopontocerebellar tract, ataxic hemiparesis will develop. What basically that means is that obviously there will be a hemiparesis occurring. That is traditional feature. I mean, stroke will obviously contribute to a hemiparesis, but there would be ataxia and features of cerebellar involvement on the same side of stroke. The reason for that is damage to this corticopontocerebellar pathway. It's a descending pathway that supplies the cerebellum. Cerebellum needs input. If it does not get input, it will have a sense of imbalance. So on the side where the on the side where the small vessel stroke is occurring, on that side there would be ipsilateral ataxia, and along with that there would be a contralateral hemiparesis developing. I mean, that contralateral hemiparesis is always understandable because of the involvement of the corticospinal pathway traversing through the internal capsule and crosses the opposite side of the body. But this descending corticopontocerebellar pathway, this is the one which is gonna go into the cerebellum the same side, which is why ipsilateral ataxia is described, and therefore the term is ataxic hemiparesis. The last manifestation is called as dysarthria and clumsy hand. Again, the point is because of the facial weakness, because facial muscles, I mean, obviously the important part of the speech would be related to the vocal cords and would be related to the functioning of the vocal cords as well as the functioning of the tongue. Our tongue touches our hard palate sometimes when we are speaking. So I mean, speech is a complex interplay of multiple factors which result in effective generation of words that actually make sense. But if there is going to be facial weakness, then again there can be impairment with respect to delivery of speech. And the fourth manifestation here would be called as dysarthria and clumsy hand. The site of lesion in this particular case would be answered by you as the genu of the internal capsule. Genu is the area where the curvature was occurring with respect to the internal capsule. This is where the face was. If there's a facial muscle weakness, again speech a delivery can be hampered. Plus there can be involvement of corticobulbar fibers related to the vagus as well, and as a result of it dysarthria can be explained. These are four manifestations of small vessel stroke. And overall, I can say that though this topic took a while to discuss, but then the most important part of this video is gonna be mainly related to stroke interventions. What are you gonna do in the first 6 hours? What are you gonna do between 6 to 24 hours? And well, these are the details to be remembered. Thank you so much for your patience and hearing me out. Keep the pressure on, keep hammering, and keep learning new facts like you have learned for this particular video, and you'll break on to the other side.